It is my pleasure to discuss with you today on the topic of corticosteroids for the treatment of COVID-19. I would like to acknowledge Dr. Rob Fowler for helping develop this presentation. I have no conflict of interest to declare. First of all, let us discuss about inflammation associated with COVID-19. This is our current understanding of the SARS-CoV-2 induced host immune response. SARS-CoV targets cells through the viral structural spike protein that binds to the ACE2 receptor. In the early stage, viral copy numbers can be high in the lower respiratory tract. Inflammatory signaling molecules are released by infected cells and alveolar macrophages in addition to recruited T lymphocyte, monocyte, and neutrophils. In the later stage, pulmonary edema can fill the alveolar spaces with hyaline membrane formation compatible with early phase ARDS. Findings that suggest lung inflammation, such as ground glass opacities and air bronchograms, are commonly seen on CT lung imaging of patients with COVID-19. Pathological findings of COVID-19 associated with ARDS demonstrated interstitial mononuclear inflammatory infiltrates dominated by lymphocytes suggestive of lung inflammation. Moreover, serum inflammatory markers such as C-reactive protein, interleukin 6, 8, 10, and TNF-alpha were found to be more elevated in ICU patients with COVID-19 who did not survive compared to those who survived, suggesting that cytokine storm may result in worse outcome. However, subsequent studies show that ICU patients with COVID-19 and ARDS had circulating cytokine levels that were lower compared to patients with bacterial sepsis and similar to other ICU patients. These findings suggest that COVID-19 may not, after all, characterized by cytokine storm. So what are our previous experience with corticosteroids in other viral pneumonias? Our experience of corticosteroid use with other viral pneumonias such as influenza, SARS-CoV, and MERS-CoV had not been positive. There were evidence that suggested a delayed clearance of viral RNA in viral pneumonia caused by SARS-CoV and MERS-CoV, whereas a meta-analysis of over 6,000 patients with influenza pneumonia showed an increase in mortality with the use of corticosteroids. Based on our previous experience with other viral pneumonia, early recommendation on the use of corticosteroids in COVID-19 have been mixed. In March, the WHO recommended against the use of systemic corticosteroids in patients with COVID-19. However, the Surviving Sepsis Campaign guidelines suggested the use of systemic corticosteroids in patients with COVID-19 and ARDS who required mechanical ventilation. Despite the mixed recommendation on the use of corticosteroids in patients with COVID-19, there has been some evidence of its early clinical use in patients with COVID-19. In an early Chinese cohort of 138 hospitalized patients with COVID-19, approximately 45% received systemic corticosteroids. A higher proportion of ICU patients received systemic corticosteroids compared to non-ICU patients. In a cohort from the ISICEM, which collected data from approximately 86,000 patients from 545 sites and in 42 countries, approximately 29% of the patients received systemic corticosteroid. So what are the early evidence to support the use of systemic corticosteroid in patients with COVID-19? In March, a group from China conducted an observational study and showed that among the 84 patients with ARDS, the administration of methylprednisolone appeared to have reduced the risk of death in patients with ARDS with a hazard ratio of 0.38. What about higher levels of evidence? Since then, we had multiple RCTs investigating the benefits of systemic corticosteroids in patients with COVID-19. In July, a group from the UK published a multi-center controlled open-label trial comparing the use of oral or intravenous dexamethasone or to receive usual care alone. The primary outcome was 28-day mortality. A total of 2,104 patients were assigned to receive dexamethasone and 4,321 patients to receive usual care. 23% of patients in the dexamethasone group and 26% of patients in the usual care group died within 28 days after randomization. The absolute reduction in mortality was 2.8%. The benefits were greatest for patients who were receiving invasive mechanical ventilation at the time of randomization, with mortality of 29.3% for dexamethasone versus 41.4% for usual care. The survival benefit was followed by those receiving oxygen therapy without invasive mechanical ventilation. However, there was a trend towards worse outcome with dexamethasone among patients who did not require respiratory support. The positive signal seen in the recovery trial had led most ongoing corticosteroid trials to suspend recruitment. 3 of these studies were published in JAMA on September 2nd. One of these studies is a REMAP-CAP RCT. A total of 121 sites in 8 countries participated in this study, contributing to a total of 384 randomized adult patients with suspected or confirmed COVID-19. 143 patients were randomized to fixed-dose hydrocortisone, 152 patients to shock-dependent hydrocortisone, and 108 patients to no hydrocortisone. The primary outcome was organ support free days within 21 days. They demonstrated that the median adjusted odds ratio with Bayesian probability of superiority were at 1.43 and 93% for fixed-dose hydrocortisone respectively, and 1.22 and 80% for shock-dependent hydrocortisone respectively, compared to no hydrocortisone. Another multi-center study conducted in France, the CAPE COVID trial, was published in the same issue of JAMA. In this study, 9 French ICUs contributed to a total of 149 randomized adult patients in the ICU with COVID-19 related acute respiratory failure. 72 patients were randomized to intravenous infusion of hydrocortisone and 73 patients to placebo. The primary outcome was treatment failure at day 21 as defined by death or persistent dependency on mechanical ventilation or high flow oxygen. 42.1% in the hydrocortisone group compared to 50.7% in the placebo group had treatment failure at 21 days. Due to the early stopping of the study was underpowered to find a statistically or clinically important difference in primary outcome. On day 28, 39% of the patients had at least one episode of nosocomial infection. The third RCT that was published in the same issue of JAMA, the CODEX trial, was conducted in 41 ICUs in Brazil with a total of 299 adult patients with confirmed or suspected COVID-19 and moderate to severe ARDS. 151 patients were randomized to dexamethasone, 20 milligrams per day, and 148 patients to standard of care. The primary outcome was ventilator-free days during the first 28 days. The mean ventilator-free days to day 28 was 6.6 days in the dexamethasone group and 4 days in the standard care group. There was no increase in adverse event in the dexamethasone group. As of July 24, 2020, 55 studies of corticosteroids for the treatment of COVID-19 have been registered. The WHO developed a protocol for prospective meta-analysis of ongoing RCTs in order to generate timely, reliable data on the efficacy of corticosteroid to guide clinical management. The objective of this meta-analysis was to estimate the association between administration of corticosteroids compared with usual care or placebo, and 28-day all-cause mortality in ICU patients with suspected or confirmed COVID-19. 7 trials were included in the final meta-analysis. The corticosteroid group included dexamethasone and low and high dose, low-dose hydrocortisone, and high-dose methylprednisolone. The DEXA COVID-19 trial and CODEX trial only enrolled patients receiving invasive mechanical ventilation. For the recovery trial, only patients who received invasive mechanical ventilation and randomization were included. The REMAP CAP and the steroid SARI trials only enrolled patients admitted to an ICU. The CAPE COVID trial enrolled patients admitted to an ICU who were receiving a minimum of 6 liters per minute of oxygen, whereas the COVID steroid trial enrolled patients receiving a minimum of 10 liters per minute of supplemental oxygen. A total of 1,703 patients were randomized, 678 patients to corticosteroid and 1,000 to usual care. The summary odds ratio were 0.66 for all-cause mortality. Adverse event varied across trial, but there were no suggestion that the risk of adverse event were higher in patients assigned to corticosteroid. The bottom line include the following. Glucocorticoids appear to increase survival in patients with COVID-19. Effects may be greatest among those with high severity of illness. The effect appears similar among many formulations. Glucocorticoids are now standard of care for sick, hospitalized patients with COVID-19. Thank you.